Sweet. All right, guys. Welcome to Alabama EMS Challenge. Thanks to Springville Fire Department for having us. Always great to come out this way. Great group of people. We are going to be here lectures 9 to 11, and then we have skills labs starting about noon to 2:30. We got the EMS fellows and also a senior resident out here. We'll be doing surgical airways. We have the ultrasound, do some ultrasound training, some advanced airway management, and then some mega codes. So if you're in the area, please come out. This is the last class for the year, but we start back hot and heavy in January. That went quick. So for those of you that are new to EMS Challenge, we started this in 2014 to bring physician-led Con Ed to the region. We started out doing one Wednesday a month. Thanks to support of numerous agencies and now the Fire College, we're able to do this twice a month with skill labs. So really appreciate that support. But the goal is to help improve patient care overall. We really appreciate what the local EMS providers are doing. We got some new updates coming up. We'll be at Birmingham Fire and Rescue Station 2 on January 11th. Also in February, the second Wednesday, we're in Aniana. The third Wednesday of January, that's a change. Normally the second and fourth, but we got our physician conference in Tampa. So January 18th will be in Aniana. In February, the fourth Wednesday, we're at Childersburg. In March, tentatively, we'll be at the Super Speedway that fourth Wednesday out there doing EMS Challenge. And of course, every challenge we have the skill lab. Just some friendly reminders. I know I show this a lot. Remember 12 leads. If you're doing a 12 lead on somebody in this region, you need to make sure you do it early. All right. And you want to either transmit that or make sure that gets on the documentation somehow, either electronically or the paper copy to the hospital, or you can, yeah, those are the options. I lost it. When charts go to the state and then a hospital tries to pull up the chart, a lot of times the 12 lead is lost. Hospitals are really looking now hot and heavy at our documentation because of billing purposes, and that's a great thing for us. It gives us leverage to be able to start doing some data exchange so we get feedback. We have access to kind of link in and get billing information, and more importantly, old EKGs, hospital destination choice, past medical history on patients. So very important, 12 leads early on these folks. If it's STEMI or no STEMI, that needs to be written in the documentation in the narrative form for you guys. So if I did a 12 lead on a patient, and it's 902, I'd put in my narrative, 12 lead 902, sinus rhythm rate of 76, nothing fancy, then put either STEMI or no STEMI. That way these hospitals, when they're going back to look at this, they can kind of get first point of contact when you got the EKG and was there a STEMI the first time. But again, this gives us great buy-in with the hospitals. I got meetings in the next couple of weeks talking about some data exchange for the BRIMS region. So the other good thing is good patient care, right? So time is muscle. If somebody's having a STEMI, you want to do that pretty quickly, right? So the 20-year-old with chest pain, I'm probably going to do a better assessment, get some vitals, and not move so fast for that 12 lead. The 60-year-old with diabetes and hypertension having chest pain that's sweaty, they're going to be early hands-on, quick 12 lead. If they're having a STEMI, get them in the STEMI system. Capnography, looking regionally, capnography documentation is lacking. We got to get better. So the only way to prove you got a tube in the right place when you place an ET tube is waveform capnography. So even if where you're working, you're able to transmit data and get that put in electronically to your PCR, make sure you put in your narrative to protect you and your agency, and more importantly, the patient. If you place an ET tube as a medic, you got to document that you see a waveform and the number on that capnography, okay? If you're ALS, if you're a medic and you have access to capnography and you place an iGels, iGel should give you a waveform capnography too, okay? If you're an EMT or BLS agency, you don't have access to that, no harm, no foul. Use the iGel, confirm it normally. But if you have access to capnography, use that as well. Epidosing, there's some changes coming down the pike with ACLS, AHA, some of the data. For time to first dose epi is pretty important in cardiac arrest, but we need to kind of start spacing those things out after that. Every 5 minutes is very reasonable. So first epi pretty quick. After that, start spacing out. Narcan, remember Narcan only reverses opiates. If the patient is breathing, there's no reason to give them Narcan. The goal of Narcan is to make your patient breathe. If someone's already breathing, protecting their airway, and they're just a little bit altered, and you give them Narcan, what are they going to do? Wake up and give you grief, right? So the goal of Narcan is to make them breathe. There's no role of Narcan in cardiac arrest. All right, if somebody's in cardiac arrest due to an opiate overdose, The first drug should be airway management, and the second drug should be epi, right? Cool. Solumedrol, are y'all carrying solumedrol out here? Yeah, solumedrol is a great drug. The only contraindications would be if someone's a diabetic or they're pregnant, all right? However, if someone's sick, dying in front of you from acute asthma, anaphylaxis, unresponsive to epi, if they need solumedrol, that's still reasonable. Toradol, we carrying Toradol out here, Chief? So Toradol is also a pretty good drug. It's a non-steroidal anti-inflammatory. But remember, the dosing of Toradol in our state protocols is 60 and 30. I would cut that in half. Max dose of 30 IM, max dose of 15 IV. People who have kidney problems, people who are older should not get Toradol. So if they're over 60, 65, stay away from the Toradol. If they're pregnant, stay away from the Toradol. If they have any kidney problems, stay away from the Toradol, okay? If you got to go to your narcotics, that's reasonable. Yes, sir.
Will you talk about the indications for Toradol and pain management?
Sure. Yeah, so
Fractures, are we talking Toradol? Are we talking fentanyl?
yeah, I think it's based upon the patient, right? So if somebody's got an open ankle fracture, I'm probably going to be hitting them with some fentanyl and morphine and not the Toradol. If you want to use some pain control for the young, healthy person who has an ankle sprain or a knee injury or something minor, not from an MVC, I think Toradol is reasonable. If someone thinks they have a history of kidney stones, so they're young and healthy, Toradol is fine. Kidney stones aren't kidney disease. But Toradol can cause some bleeding issues. It's also bad for the kidneys. Some of the ortho guys don't like it as far as bone growth as well. So it's an alternative to the opiates, but it's not the best alternative for our patient population. Most of the folks in Alabama are old, have health problems. So for me, if I'm using Toradol, it's that young person with the ankle sprain, knee pain, hip pain, maybe low speed MVA that I'm underwhelmed with. I might do some Toradol if I have to. But there are other places that I work that we're just not even going to use Toradol altogether. We have to carry it by state, but we're not going to use it.
What we're seeing is have people that have a tendency to be a little afraid to, given the fentanyl and the opiates because it's such a strong.
Right.
So they want to give Toradol first to see how that works. And,
Yeah.
You just got someone with a broken leg and they're sitting there in pain.
Yeah, give them the fentanyl, the morphine. Yeah. So, our job in the EMS world and ER world is to help alleviate the pain. We're not going to take it all the way. But if somebody has a significant injury and they're hurting, they're uncomfortable, treat their pain the best that we can. Okay. And Toradol sometimes is not the best drug for that, in my opinion. Cool. And then those were friendly reminders. This is an unfriendly reminder about using capnography. You can Google esophageal intubation. There are law firms that work strictly on doing things like this, looking for malpractice. A lot of this is hospital-based lawsuits, but you guys are open to that as well. I cannot stress enough, you've got to document that you see waveform and the number for capnography in the narrative and in your charting if you place an ET tube. If you can't confirm it that way, you're probably better off not putting a tube in somebody and doing old school nasal trumpet, passive O2, BVM, OPA, oxygen, BVM, or an iGel, right? So capnography, very important, will keep you out of trouble. All right, I'm gonna pass it off to Dr. Melissa Willett.
All right, good morning, everybody. Good morning. Thank you for having us, and thank you to Springville for hosting. We really appreciate it. Most of y'all have met me or seen me by now, but if you haven't, I'm Melissa Willet-Caldwell. I'm one of the UAB emergency medicine doctors and EMS fellows working with Dr. Ferguson this year. So today we're going to talk about congestive heart failure. This is a pretty complex disease. It's going to be a little heavy on pathophysiology, so warning ahead of time, okay? So eat your breakfast sandwiches, get ready. So we'll talk a little bit about cardiac anatomy, okay? Definitions and classifications of congestive heart failure, which in advance, let me tell you, is confusing. So we're going to talk about all the different ways that it's defined and classified and hopefully simplified a little bit for everybody. Some pathophysiology, what happens when we get dysfunction of the heart that leads to CHF. We'll talk about medications and treatments that are commonly used for this disease, different types of presentations, what you may see when you get called out to a CHF patient. Some complications, pre-hospital treatments, your protocol, and then if we have time, we'll go over a couple cases. It's a lot. All right, so anatomy. cardiac anatomy. So the important thing is the directional flow of blood, what is happening during each part of the cardiac cycle, and systole and diastole, right? So blue, right side of the heart is deoxygenated blood, right? You guys all know this, right? So this is blood that's returning from the body. Every cell has pulled out all the oxygen, has extracted it for use, and then it's returning via the superior vena cava and the inferior vena cava back to the right atrium, okay? So it goes in the right atrium, through the tricuspid valve into the right ventricle, okay? And then this gets pushed through into the pulmonary arteries and into the lungs. This is where gas exchange happens. It gets all the new fresh oxygen, and then it goes back through the pulmonary veins into the left atrium, through the mitral valve into the left ventricle. It's red because it has oxygen, and then it squeezes, and then it goes out through the aorta into the body, okay? So this is all review, I know. But in heart failure, right, so we will talk about left-sided disease and right-sided disease and what happens when either one of those sides are affected, okay? And then when you think about systole and diastole, so systole is contraction, right? And we usually refer to it as the ventricles because you have atrial systole and diastole, you have ventricular systole and diastole. But when we say it, we're typically referring to the ventricles because that's the important part, right? So systole is pumping, right? That's when the heart squeezes and blood gets ejected, right? And it happens at the same time, both for the right and left sides, right? So it's getting pumped into the lungs and it's getting pumped into systemic circulation at the same time. Diastole is relaxation. So the heart squeezes and then it relaxes. And when it relaxes, it fills, okay? And so you can get problems during any of this entirety of the cardiac cycle, and it has different consequences, okay? So a little bit about definitions. So heart failure, right? And sometimes you'll hear it referred to as congestive heart failure or heart failure. So cardiac dysfunction. This is due to many, many, many different reasons. We'll talk about some of the many, but not in detail because we just don't have enough time. But they're either a structural or a functional issue, dysfunction of the cardiac muscle and tissue. And then this abnormality, the big picture thing is that it leads to decreased cardiac output. So this dysfunctioned heart just cannot push blood forward as well as it used to, as well as it should, okay? You will hear us refer to ejection fraction, and that's simply a measurement of the percentage of blood that gets ejected from the heart during each cardiac cycle, right? So when the heart squeezes, how much blood gets pushed through into systemic circulation. Normal is about 55 to 65%. That is a normal EF. But some patients who have severe heart failure, that's less than 20%, right? And so I have a video in here, cross my fingers that it actually plays. But I mean, some hearts you'll see if you put an ultrasound probe on the chest, they're just quivering. I mean, they're barely pumping. And then exacerbation is just an acute worsening of a disease, right? We have asthma, we have COPD exacerbations, we also have CHF exacerbations, right? So we talked a little bit about systole, we talked a little bit about diastole already, but also heart failure can be defined as systolic dysfunction or HFrEF, so heart failure with reduced ejection fraction, okay? And then decreased forward flow of blood. But there's also diastolic dysfunction or HFpEF. So that's heart failure with preserved ejection fraction. So that heart's still squeezing fine, but the problem is in diastole. The problem is it doesn't relax well enough. The ventricles are really stiff. And so when heart tries to fill, the ventricles don't relax. They don't accommodate enough blood. And that also decreases the amount of blood that moves forward. They also talk about left-sided heart failure, right? So the left side is what pumps fluid forward into systemic circulation. And what's immediately behind that, where that blood is coming from, is the lungs. So if fluid isn't moving forward because the left side isn't working, then it's backing up mostly into the lungs, okay? So typically more pulmonary symptoms, not always, I say typically because that's kind of how we teach it. Some common causes, this is not exhaustive, is coronary artery disease, and MIs, and then hypertension leads to a lot of left-sided dysfunction. Right-sided heart failure, typically more peripheral symptoms, right? Because the right side, if it's going to back up, it's going to back up into the periphery first, right? So you think of more JVD, edema, abdominal swelling. Again, this is typical, right? This isn't always the case because the most common underlying causes for right-sided heart failure is left-sided heart failure. So often if someone has right-sided dysfunction, the left side is not working as well. That is not always the case, because sometimes pulmonary issues like COPD, like in an acute situation, a PE can cause fluid to back up into the systemic circulation because the lungs aren't working well, right? We have high pulmonary pressures that's causing fluid to back up. But also like a right ventricular MI, right? A heart attack up the right side can do it as well. So then there's classifications, right? So the most common is the New York Heart Association classifications, and you may just hear these. This is just more of an FYI. So 1, 2, 3, and 4, increasing the number increases the symptom severity for the patient. We don't really talk about that in the pre-hospital world. But this is confusing, right? So we've talked about heart failure, congestive heart failure, left-sided heart failure, right-sided heart failure, biventricular heart failure, where you have right-sided because the left side is down. Systolic, diastolic, and then we talked about the NYHA classifications, okay? So a few years ago, cardiologists got together and was like, this is confusing, right? This is a lot of different ways we talk about it, so we should have some common way to think about it. And so I just kind of give you that background, one, so you guys understand how complex of a disease this really is. And there is a lot of systemic issues that arise because of problems with cardiac dysfunction. But the big thing that I want you to take away is, and again, diagnostic tools are limited in the pre-hospital world. So a patient's just going to be like, I have heart failure, but you're not going to know all the subtleties around it. Maybe you'll have like a very educated patient that really knows a lot about their disease and can give you some insight, but you may not know. That's probably not going to be the case. I see a lot of like, absolutely not, head shaking, right? So really, I just want you to know that there's a lot of different ways you get to heart failure, but all it essentially is at the end of the day is the heart either is not contracting well or it's not filling well, both of which lead to poor downstream flow of blood, okay? So you have reduced cardiac output. That heart is not functioning normally. And at the end of the day, a lot of the consequences and certainly a lot of how you treat it is going to be the same, okay? So, pathophysiology, these are ways in which you arrive at heart failure. All right, so cardiomyopathy just means heart muscle badness, cardiomyopathy. So dilated, hypertrophic, and restrictive are types of that. And there's a lot of genetic underlying components that contribute to developing that. There's ischemic, so if you have a heart failure, like if you have a heart attack, that certainly can cause dysfunction and poor function of your heart. Long-standing hypertension over time certainly can do it. Toxic, so this includes both medications that we give, like amiodarone, can cause a lot of pulmonary dysfunction over time, or I'm sorry, cardiac dysfunction over time and pulmonary. But also alcohol abuse can do it, cocaine and stimulants can do it, and typically not, you know, someone had a real fun night, but like if you do it a lot over time, right, it will poison your heart. Postpartum, so women can get postpartum cardiomyopathy, and so within typically weeks after giving birth, they may develop acute symptoms related to it. There's congenital things that can lead to it, valvular, and this is not an exhaustive list. And something that I thought was really cool and interesting is some heart failure is reversible. So sometimes you can get an acute insult, right? So a patient has a heart attack, or you know they have a PE, or they had some acute insult to their heart, which causes damage to the muscle or to the tissue, right? Say they get hospitalized, maybe they need to be put on a inotropic drip, maybe they go home on dobutamine or milrinone. Maybe they need an LVAD, which is a little precursor into the next lecture, right? But then sometimes the heart will recover amazingly, and they will have, you know, like their ejection fraction will improve. They'll be able to get off those medications and go back. Life goes a little bit back to normal. This is not always the case, but it's pretty cool that can happen. All right, so we're going to talk a little bit in depth more about left-sided heart failure. And this is a busy slide, but I'm just going to kind of talk through the physiology. So the left side of the heart, right, feels too much pressure or too much volume, okay? It cannot push that blood forward. So the blood backs up. It backs up into the lungs. This increases the pulmonary pressure, right? This leads to pulmonary edema or congestion. That's why you get the symptoms of shortness of breath. They are often tachycardic because that heart's working really hard. They're trying to breathe. This also compromises forward blood flow, right? So this leads to badness for downstream organs, mostly the kidneys, but certainly other organs as well, okay? You get peripheral malperfusion. So you're getting a low, what the downstream organs perceive as a low flow state, okay? And then they will react to this because there's a ton of body systems that work in concert. They try to help each other, right? So the kidneys say, uh-oh, I'm not getting enough blood flow. This is a problem. They start releasing substances that will constrict peripheral vasculature, right? Which seems great in the short term, but because this is a chronic problem, now the heart is working harder against constricted vessels, right? So this already damaged heart is now having to work harder. It also causes chronic inflammation. So you get a lot of substances circling in the blood that's just causing more damage to tissue. And then you also get sympathetic activation, right? The heart's not working, right? And so you get all these like substances released that may try to push the heart to work harder at a time where it's already damaged. And we'll talk a little bit more in depth about that. So I like this little diagram. I don't know how well you guys can see it from there, but it gives a nice little kind of cartoon about what is happening, right? So you get pulmonary congestion and pressure from fluid backing up. The downstream organs get upset because they're getting low perfusion. They think it's hypoxia and they start reacting to that, which in the long run causes more problems. It's kind of like this vicious cycle. So with right-sided heart failure, you get volume or pressure overload in the right side. This leads to right ventricular hypertrophy and dilation. So it sees this pressure, and the right side of the heart is not as muscular, right? It will dilate faster, right? It can only accommodate so much, but it will try to accommodate it for some time. So eventually these filling pressures, the amount of fluid in there increases. You get some tricuspid regurgitation. So the valve between the top and bottom side of the right heart stops working as well because, it is stretched out. Think of it like that. So you get more right volume overload, more enlargement. Fluid starts to back up in the peripheral tissues, right? So you're getting a lot of venous congestion, you get JVD, you're getting, say liver congestion, abdominal distension, peripheral edema. And then over time, this can cause chronic pulmonary hypertension, which we refer to as cor pulmonale, which is a very bad disease. Patients have to go on a lot of specific medications for that. And these patients in particular are very preload dependent. So you may see them on like sildenafil, and you might be like, why is this female patient on sildenafil? And it's not because she has erectile dysfunction. It is because it's a smooth muscle relaxer, right? So it's for her lungs. And these patients, again, their volume status is very tricky, right? So if I see patients on some of those medications, if they're doing okay, I'm going to be very cautious when I give Lasix. I'm going to be very cautious if I slam them with fluids more than I would maybe, someone who doesn't have that permanent damage to their lungs as a result of the heart failure.
So are you saying, quick question.
Go ahead.
Are you saying that the right-sided heart failure causes the cor pulmonale or the pulmonary hypertension, or is that vice versa? I always thought it was vice versa.
So yeah, it is a little bit of like a chicken and the egg, right? So cor pulmonale, when you have a lot of pressure, increased pressure in the lungs, things will back up, right, into the right side of the heart. But if you have increased pressure in the right side, it also will lead to increased pressure in the pulmonary vasculature as well. So compensatory mechanisms, right? So this is still certainly pathophys, right? This is the neurohormonal activation that I was talking about. So when your downstream organs feel like they're in a low flow state, when they're not getting that blood flow because cardiac output is compromised, it causes a lot of activation of different systems in the body, right? So one of the big ones is the RAS system. Kidneys play a big role. There's also some other organs involved, but this releases signals that affect vasoconstriction, your sodium levels, and your blood volume. So when the kidneys say, oh, I'm not getting enough blood flow, they will clamp down on the vasculature. They will release substances that make you retain water and retain sodium, because when you retain sodium, water follows, right? So that is interestingly why a lot of patients that are volume overloaded really, really want to drink water. Like, so we have those in the hospital and we're like, you need to be on fluid restriction, but they're so thirsty. Their sodium levels are up because their body is trying to hold on to fluid, which is the opposite of what they need. So this affects blood pressure, and this makes the heart work harder, right? So when your SVR is increased, that heart is pumping harder. It's working harder against downstream resistance, right? When your afterload goes up, your heart has to work harder. And then also the sympathoadrenergic system. So this is your fight or flight system, okay? When it feels like the heart is not working hard enough, right? If it's saying, you know, downstream, the heart's not doing its job. We feel like we're hypoxic. We feel like we're not getting enough oxygen and blood. It will release chemicals to make the heart work harder, right? So a lot of these patients are kind of chronically tachycardic. They're on a lot of beta blockers, not just for that, certainly not for that, but that is a very unfortunate consequence of it. So it ends up becoming toxic to the heart, releasing substances that are causing more damage to the heart over time, right? So again, it's this kind of vicious cycle. And common treatments. So lifestyle modification is a big one, right? So we ask these folks to be on low salt diets, we ask them to fluid restrict, and we ask them to do gentle exercise. These are things that are very hard to adhere to, even for healthy people. And then also medications you may see, these are very, very common for patients who have heart failure. Does anyone get the reference, the AC/DC reference? What is it? Yeah, well, it's the song Shoot to Thrill, Too Many Women, Too Many Pills. All right, so common treatments, right? So this is when patients have progressed to pretty severe heart failure, right? So at this point, you know, it may be acute, it still may be reversible, but regardless, if their heart failure is so severe, they may need support from these more invasive, more serious treatments. So patients might be on inotropic drips at home, dobutamine, milrinone drips, they have PICC lines, they have pumps, right? ICDs and pacemakers, so when you get a lot of stretch in the heart, and also some of the chemicals that are released and that are affecting the heart make these folks prone to dysrhythmias, dangerous dysrhythmias. Sometimes they have chronic hypoxia and they're on home oxygen. So they also may have LVADs, so left ventricular assist devices. And this is when the heart is pumping so poorly, it cannot move enough blood flow. So you may need an external device to help do that. And Dr. Gros is going to talk about that after my lecture. And then the LVADs can be either a destination therapy, so that's it for life. Like they have the LVAD and that's it, okay? Or it can be what we call a bridge therapy. So if these patients are on a heart transplant list, they may need an LVAD while they're waiting for their heart. And then heart transplant, if they are eligible. Okay, so different presentations. So you can have heart failure exacerbation, but these patients are normotensive, maybe hypertensive, but they're not hypotensive, right? So this is the most common thing you see, right? Maybe it's because, you know, oh, I went off my diet, I stopped taking my Lasix, I ran out of medications, or, you know, maybe something else is going on, they have an underlying infection, something tipped them over the edge, right? But for whatever reason, and sometimes we can't always put our finger on it, over days to weeks, these patients develop volume overload, right? So, and it could be an insult that further reduced their heart function. It could be any multitude of reasons, right? These patients can still be altered because their biggest issue is volume overload. They might be hypoxic, right? So they may need a little oxygen support, but from a cardiovascular standpoint, they, you know, they are relatively normo or hypertensive. So these pictures are JVD. You know, sometimes you can get peripheral edema that ascends so high it's in patient's belly, which is pretty impressive. You can get abdominal distension. And Sweet. All right, so that's pretty severe heart failure. If you can see that heart is not pumping well. So that's probably an apical 4-chamber view. So hypotensive heart failure or cardiogenic shock, right? So this is volume overload, but also poor perfusion. So for whatever reason, that person has tipped over and they are not perfusing their downstream organs. They are hypotensive, they have cool mottled extremities, weak and absent peripheral pulses, they're altered. Often they have low or no urine output, they're shocky. These patients are very, very sick, and likely need some intensive interventions from you guys and then pretty rapid transport because they are probably going to be headed to the ICU when they get to the emergency room. And then another thing you may see is flash pulmonary edema, severe respiratory distress due to just an immense amount of fluid in the lungs. These patients also tend to be hypertensive, pretty profoundly hypertensive. They certainly may be altered. Again, these patients are very sick, and these are potentially dangerous intubations. We take these very seriously in the hospital, which is, the best of settings where we have all the support and resources. And that's because these patients are tired and their reserve is very, very poor. You need to really be ready to go to get that tube as quickly as possible because they are going to drop like a rock. So these are just some pictures of flash pulmonary edema. Like those are very, very wet lungs with a lot of just like fluffy infiltrates. And this just kind of shows a view of the alveoli and just where the pulmonary edema collects. And when all this fluid is in there, there's really no room for gas exchange, which is what causes the hypoxia and all their symptoms. All right, so complications, and they are, some of them are pretty significant. So cardiogenic shock, we talked about that a little bit. Those patients are very, very sick. They often need both support from a blood pressure perspective with pressors, ionotropes to help recruit and get that heart to function. They may need intubation for airway protection. And then flash pulmonary edema, also very, very sick. Cardiac dysrhythmias, again, these patients often will have ICDs, defibrillators placed. They're prone to some dangerous dysrhythmias. Certainly cardiac arrest, chronic hypoxic respiratory failure. A lot of these folks are on home oxygen. Cor pulmonale that we kind of talked about a little bit. And then if this gets bad enough, these patients may have LVADs and they may eventually require heart transplant. So this is your protocol from the Alabama EMS treatment protocols, 10th edition. So things that we think are important that you talk about with your patient is acuity and onset of symptoms, that careful history of fever, chills, purulent sputum. Sometimes they may have an underlying infection that kind of tipped them over and needs to be addressed. Chronic lung or heart problems, right? Are you on home oxygen? Why aren't you wearing it? We think it's important. I would say all these patients are going to get an EKG en route at some point, but asking about associated chest pain, because you can get acute causes of heart failure. Again, if you have a pretty centralized PE, that can cause this. Vital signs, certainly a full set of vitals, certainly a pulse ox, and then titrate oxygen as needed. Level of consciousness, cyanotic, things like that. And then signs of congestive heart failure. So key points in your protocol, right? Listening to breath sounds. You can look at someone and know if they're volume overloaded, right? You can see if someone's having difficulty breathing, but these patients often have crackles, they have rales if it's really bad. But early CPAP, BiPAP is important, right? So we like CPAP because not only does it help with work of breathing, if patients are working really hard, they cannot sustain that forever, right? So that will help with work of breathing, but also it pushes, that positive pressure will push fluid out of the lungs. It truly will help their symptoms. And then nitro, just to reduce afterload and to reduce the amount of work that the heart has to do, okay? If someone's in cardiogenic shock, their blood pressure is low, no nitro, no nitro, but you guys know that already. And then oxygen as needed, right? We like it greater than 92%, sit them up, and then of course, cardiac monitor, and all of these patients should be getting a 12 lead. If you use ESO, please upload your 12 lead. Okay, so they talk about this cardiac wheeze, right? It's not gonna help, right? Like, yes, sometimes you may hear it and you're like, huh, But albuterol is not going to help this because that's not the problem. Certainly, do you have patients who have COPD and they have CHF? Yeah. Sometimes do I treat both? Do I think we have like this mixed picture in the hospital? Yeah, I do sometimes. But I would use caution in the sense that, you know, it's ideally a short transport time. We have more diagnostic tools in the emergency room. And certainly if someone's heart rate is 120, they look wet, you can, you know what I mean? Like I wouldn't further stress the heart with albuterol, right? Because if they have a mixed picture, if there is a COPD exacerbation, like, yeah, it actually may help that, but sometimes it's hard to be sure. And these patients are fragile. So I'm not saying you can't do it, but just exercise caution before you do. All right, so a little bit more on this, right? It depends on the type and severity of symptoms, right? So if someone's hypoxic, let's give them oxygen. If they're working really hard, or if they're exceedingly volume overloaded, if they're in respiratory distress, but they're still alert enough that they can tolerate it, CPAP is awesome, right? So we love CPAP. Lasix, like, can you give a slug of Lasix pre-hospital? Sure, right? It causes hypokalemia and hypotension, so just use with caution, right? Ideally, you have short transport times. I have some colleagues that if they, like they want to see the potassium before they give Lasix, I don't. I just give it. If you're volume overloaded, you're going to need it. I'm going to give it. I can give you potassium back when my labs come back if I need to. But, you know, low potassium, we care about that, right? It can cause cardiac dysrhythmias. It can cause problems. So just be aware, right? So I'm not going to be upset if somebody starts the process of diuresing in the pre-hospital world. But if they're hypotensive, right, if they look like they can wait till you get to the hospital, that's fine, right? Nitro reduces afterload and flash pulmonary edema. It reduces the amount that the heart has to pump against and work. So it is awesome, right? But of course, nitro causes low blood pressure, right? It can cause that. So just be careful, right? And then inotropes, dobutamine, dopamine, pressors, epi, phenylephrine, levophed. And we can talk a little bit about which is the best one to use and what the literature supports in a second. So it's okay to consider a baby bolus sometimes in these patients. And I'm not saying if the patient looks volume overloaded, right, like give them fluids, right? We always say like, don't use fluids with caution. They can't tolerate fluids. They have cardiac dysfunction or patients that have liver dysfunction. And that is 100% true. But if a patient who has low blood pressure, the reason we worry about it is because I don't want that to land in the lungs and cause further respiratory distress, right? Because they're third spacing, they can't handle fluids. But something that I was taught was these patients can handle some gentle fluids, you just can't slam them with it. They cannot tolerate being slammed with fluids. So it's not the end of the world if someone's not in florid respiratory distress and their blood pressures are a little soft. If you want to give them a little baby bolus, I'm not going to get mad at you for that because we're going to give them laces. We're going to fix it when you get them to the hospital anyway, okay? So just know right in the back of your mind, it's okay. It's okay. You can at least consider it. All right. Well, actually, we moved through that pretty fast. So let's do some cases, okay? All right. So case number one. This is a 68-year-old female. She has a history of CAD. She's had a cabbage. She has CHF. She has chronic hypoxic respiratory failure. She's on HOMO2, a couple liters. She has CKD. So pretty typical patient, right? So the call goes out for shortness of breath. So you get there, and she looks a little volume overloaded. She says, I've had worsening shortness of breath. Now I'm getting dyspneic when I exert myself. I can't, walk across the other side of my house as well without stopping. I have some intermittent chest pain. I've got a wet cough. And yes, my weight is up, right? So these are her vitals, and that's her physical exam. So what do you guys think is going on? What are you worried about? This is a pretty straightforward patient, right? It's just a CHF exacerbation, right? So for whatever reason, right, like maybe she's got a little pulmonary infection. Maybe she didn't tell you that it was just Thanksgiving and like, yeah, I had a lot of beer and man, I love pumpkin pie and I love salty turkey and gravy and I just went crazy. So she's mildly hypoxic, right, on her HOMO2. So just bump that up, get a 12 lead en route. She's going to the hospital. This lady, she's probably going to get admitted. If she wasn't hypoxic, like sometimes do we just like, why give patients a slug of Lasix if like all of their workup looks okay? And then I'll send them home and I'll say double up on your Lasix for 2 days. Make sure you see your cardiologist or your primary care doctor. That happens, right? We do that. But if you have a new oxygen requirement, the burden of symptoms are such that you probably need a little more just teeing up in the hospital before you go. So she's certainly somebody that needs a little attention. All right. So what about this guy? This guy, he's a little bit sicker, right? So 59-year-old guy, he has dilated cardiomyopathy. He's on a home dobutamine drip. He used to do a lot of cocaine. He's drink a lot, but he's been in remission for a couple years. And he also has a history of COPD. Okay. Still a smoker, but like I'm down to 1 a day. Doing great. Okay. So the call goes out for altered mental status. So you get on scene and he can't really tell you anything. I mean, he's purposeful. He's looking at you, you know, he's not dead, but he can't really give you a good history. Wife said over the last few days, he's just like felt a little more tired, right? A little more short of breath. But this morning she went to wake him up and he looked like this. And she was like, oh God, she called 911. Okay. So you guys are probably already thinking about some stuff, right? He's on a home dobutamine drip, right? That means his heart failure is pretty bad. So those are his vitals. That would make me nervous. I wouldn't like that, right? That's not good. That's not good. All right, this is his physical exam. So he's sick. This guy's really sick. What do you think's going on with this guy? He certainly has heart failure, but look at that blood pressure. Like, look, the key is what? He's cardiogenic shock, right? This guy is shocky. This guy's very sick. I would be very worried about this gentleman, and you should be moving quite quickly with him, right? So what are we going to do for him, right? So the first thing I want you to do is look for that Dobutamine pump, okay? Because I had a patient who family brought them into the emergency room, and it looked just like this, like same, it was a female, but it was like very similar story. And they rush her back to the recess bay. And I didn't know she was on a pump, but I'm looking through her chart and we're talking to her, nurses are getting everything together. And I'm like, what's this? And I pull up a pump that is not on. I'm like, ma'am, what is this? And she's like, oh, that's the heart pump. I'm like, oh, it's not an LVAD, thank God. But we're like, I'm looking through a chart and I'm like, well, you're on dobutamine. Ma'am, how long has this been turned off? I don't know. Awesome. Okay. But at least I know, like, okay, well, now this is clearly what we need to do to fix this problem. Like, yay, you know? So if somebody says anything about being on a drip, I want you to look at it, right? Make sure it's functioning. Often the medication's right there and it tells you how much they should be on, right? And if it looks like it's functioning, maybe they just need it to go up a little bit, right? But if it's not, please turn it on or start your own drip, right?
Say this, one
Yeah.
thing with those pumps,
Yeah.
we cannot change the rate on those pumps.
You're not allowed to?
No, it's not that. My wife does these infusions.
Oh, that's awesome.
So when they come from the pharmacy,
Okay.
they are already programmed.
Meaning
So
it's a safety, so they can't change it.
You're in there. So
Okay.
the only way for us to increase it, whether or not it's the dobutamine or something, is you have to take it off their pump.
And just do your own.
Best thing for us to do is just start a dopamine.
That's good to
But
know.
you look at it to make sure the pump's on or the batteries aren't there.
That's awesome. Yeah.
Yeah.
But you aren't allowed to monkey with
increasing
it.
the Dobutamine, you're not going to be able to change that pump.
Okay.
It's not like a pump in a hospital.
Fair enough. Fair enough. Okay. Well, that's good to know. So don't touch it, or at least you can't touch it. But if it's on, so, but it will at least let you know that one, this patient has severe heart failure, and two, we've probably identified the culprit if it's not working. If it is working, then something's tipped them and they need more anyway. And if you're not allowed to monkey with it, then get ready to start your own. Okay. And then you can consider a small fluid challenge in this guy. This is the patient that if you're like, I gave him 250 cc's, it didn't do anything while we were like, you know, getting our own drip started, I'd be like, cool, no problem at all. I mean, he's a little hypoxic, but he's not in respiratory distress, right? This is a shocky issue, less of a respiratory distress issue. You may need to start a pressor, right? We'll see. And then, you know, increases oxygen. He needs rapid transport. This man certainly needs a 12 lead, and then be ready to code just in case, okay? So just be ready. These guys are very sick. All right, great job. All right, so what about this one? So she's a 36-year-old, otherwise healthy female. She's 3 weeks postpartum. The call goes out for shortness of breath. So this is a wide differential already, right? Whenever you see like 3 weeks postpartum, I'm always like, oh God. Okay, because this could be a lot of things, right? So history is, if you wanted to know, the pregnancy was fine, the delivery was fine, everything was uneventful, it's her first child, it's healthy, everything else is great, right? No infectious symptoms. She's had about a week of shortness of breath. And now she can't walk across the room without having to stop and catch her breath. Like it scared her today. Like she was like, okay, something's really wrong. And she's got quite a bit of edema. So this could still be a couple things, right? So these are her vitals. Could still be a couple things. But she looks uncomfortable. She's pitting edema to the shins. She's a laterally displaced PMI, which is like a tip in case anyone doesn't know what that is, right? So your point of maximum impulse, I'm not routinely checking this on people, but I'm doing this to like give a little hint, okay? So if your heart becomes dilated or enlarged, sometimes it will laterally displace that spot where the heart is closest to the chest, where you can feel it actually like touch your fingers sometimes. That's just a little tip. And then crackles in bilateral lungs. So like, what could this be? This could still be a couple things. It's a heart failure lecture, so.
Did she have any preeclampsia?
She did not,
That's
but
not-
yes, that's certainly something you should be thinking about. Excellent.
Edema to her shins only or also to her feet?
It's her feet, all the way up.
Not a DV.
Nope, and bilateral. But yes, good point, good point. But yeah, certainly, this could still be an acute PE, right? Women, when they're postpartum, they are at a much higher risk for developing blood clots, right? So this still could be a PE, but it's a heart failure lecture. So, so she has postpartum cardiomyopathy. She needs oxygen. She's hypoxic, right? She's breathing a little bit fast. I mean, you could consider a CPAP in her, but it depends on what the patient looks like in front of you. And then she gets a 12 lead and she gets transported, right? But yeah, this certainly could be a PE. And I'm so glad that you said preeclampsia, because that certainly should be on your differential, right? Okay, last case, guys. 54-year-old female, history of hypertension, alcohol abuse. She's checking into Bradford. This is one of my patients too, actually. Checking into Bradford. And while they were getting the intake vitals, she was found to be hypoxic. So they called 911. Right? But she was still pretty comfortable. She was just mildly hypoxic, right? She hasn't been taking her medicine. She hadn't seen a doctor in a really long time. So the call was out for shortness of breath. So you get there and she looks terrible. She looks terrible. She just can't talk. She's tripoding. She's speaking in 1 to 2 word sentences. She's just like shaking her head. And these symptoms developed pretty quickly, right? So those are her vitals. Yuck, right? So she's got a lot of stuff going on, but what do we, right, and then here's your physical exam, right? That sucks, right? So what do we think is this one?
Flash edema.
This flash pulmonary edema, yeah. And we had a patient, I don't remember what service brought her, but she was checking into Bradford and like just crumped right in front of them. So this is flash pulmonary edema, right? So these patients are super sick. She's technically also hypertensive emergency, right? So she gets CPAP, 100%. This one gets CPAP. This one, nitro. Nitro would be very beneficial here. Rapid transport, certainly gets an EKG en route, even though we think we already know what's going on, but still, for completeness, needs it. She will probably need intubation. If she doesn't look better by the time she hits our door, she's going to get tubed, right? And these patients, like, she can only compensate for so long. Like, they're exhausted by the time they get to us typically, and they have no reserve. So these are dangerous intubations because they drop like rocks. They'll just drop like a rock. So like you got to be ready to go. Okay. But good job. Some scary patients. Oh, hold on. So in summary, right? There's many causes. There's many ways to classify. There's many routes to get to heart failure. Okay. But just know that at the end of it, it's just dysfunction of the heart such that it impairs forward blood flow. Okay. They are complex patients, and it is difficult to manage this disease. There's a lot of different treatments. There's a lot of different interventions that they often need. These patients are very chronically sick. They tend to have a lot of interface with the healthcare system, and they certainly are admitted quite a bit for exacerbations. Treatments are always aimed at preventing symptoms with lifestyle modifications, medications, treating the underlying cause, and preventing progression. And then acute exacerbations may need inotropic and or blood pressure support and often oxygen in the pre-hospital setting. I have a few more minutes. So I did say we were going to talk a little bit about pressors and inotropes and just what in the literature supports what we should be using. And the truth is that there's not a ton. There's not a ton, but there's some somewhat recent meta-analyses that really say there's not a ton of difference between dobutamine and dopamine, right? Either one is fine. Certainly in the pre-hospital setting, which, they will not be on it for hopefully not very long until they get to us, right? With dobutamine, you may also need to start a pressor because sometimes they'll get more hypotensive with that. The pressor of choice is really Levophed. They tend to have the best outcomes on that. But again, not a lot of pre-hospital folks carry Levophed. Epi, unfortunately, is associated with some worse outcomes, but that's if they're on it for a long time. So if you have epi and you need to start it, start epi, no problem, right? No problem. If the receiving hospital wants to switch it out, that's fine, okay? And phenylephrine also, like if you do dobutamine that can cause some vasodilation and then you want to start a little phenylephrine to kind of counteract that, also fine, that's great. So at the end of it, it's really whatever you carry, please use if your patient needs it, right? And things can always get switched up when they get to the hospital if they feel like they need it. So that's it. Thank you for listening to me. Thank you for going through cases with me.
I don't think many people are carrying, I don't think nobody's carrying dobutamine. All of ours are.
It's dopamine, which is fine. I mean,
Leftsided was added to the formulary.
Levophed added.
it's there, but not a lot of people are carrying it, right? So in this state, I mean, phenylephrine's on there, Levophed on there, epi's on there, but not everyone carries it. So I think the takeaway is whatever you have, use, right? Just use it.
That would be for essentially the cardiogenic shock.
That's for cardiogenic shock.
Most of the patients in my experience we encounter at CHF are hypertensive.
Yeah, and that's going to be the most common, right? Is either normotensive or hypertensive and just a flare, right? An exacerbation, which really doesn't not need that support, obviously. They may need a little oxygen, they may be a little hypoxic, right? And then just transport. And that's it.
So we had a few questions.
Yeah, go.
One, I think you've already done a good job answering was what if I have a patient with CHF exasperation plus their known COPD and they're wheezing. And I think you did a good job answering that. I think probably bottom line is if you hear wheezing, only give albuterol if you hear wheezing and then use it.
If you suspect a mixed picture, right? Yes, yes, yeah. It is not indicated for CHF. Certainly patients can have a mixed picture. They can have a mixed picture, and I sometimes do. I treat for CHF and COPD exacerbations in the emergency room. Like I have done that. But if someone's really tachycardic, they look volume overloaded. Sometimes it's more, right? 80 of one, 20 of the other, So ideally in the pre-hospital world, unless they are really struggling to breathe and they don't look wet and they don't sound wet, but they're saying my weight's up, this is my CHF, and you see a pack of cigarettes lying there, right? And their heart rate isn't through the roof already. Sure, no one's gonna get mad at you if you try it. But these patients are fragile, right? If they look volume overloaded, their heart rate's already high, I would wait, right? Because if you guys can't get a chest x-ray, right? I mean, you can listen, you can look, but a chest x-ray, if you're like, oh man, fluffy, all day long fluffy, like that's more CHF,
So there's also had a little side conversation on text here.
Yes.
People asking about, and I think this has probably gone away, but we used to find patients at home that were kind of end of life, even if they were on hospice.
Yes.
That were taking oral morphine.
Yeah.
And you get there and you treat it like it's a overdose. And then as soon as you give Narcan, they CHF exasperation. Is anybody using morphine to treat acute CHF?
So I will say
used to way back when.
Yeah. Well, I will say, so how does morphine help respiratory symptoms, right? So often at the end of life, for example, my grandma died of end-stage COPD and she got a lot of morphine, right? She got a lot of benzos. It helps them relax. It helps, it does improve their breathing. But if someone's in acute CHF exacerbation, by definition, they have too much fluid. They have too much, you know what I mean? Like the morphine isn't going to help the underlying problems of the CHF. It might help them relax a little bit, but it's not going to treat it.
Keeps their blood pressure a little lower too.
And it will help their blood pressure. That is true.
Yeah, I was going to ask like your flash patient, your Bradford lady.
Yeah.
You're giving the Lasix, you're giving nitro.
Absolutely.
I would think that morphine could be considered.
Absolutely.
For two reasons. One is it has more effect to decrease afterload, but it also helps to decrease a little bit of her anxiety. But at what point do we decrease anxiety?
At the cost of alertness? Yeah.
use CPAP?
Yeah, no, I think those are all really good questions. And we sometimes have to think about that even in the emergency department, right? So that's not necessarily a pre-hospital issue. I would say if a patient is alert and in distress, right, and you think they could derive some benefit, give it, right? If they're altered so much that you're worried about giving morphine, then you probably shouldn't even be putting CPAP on that patient either, right?
Yeah.
So you guys are very good at rapid clinical assessments and kind of knowing what your patients can tolerate and what they can't. And so I think it really much depends on what the patient looks like in front of you, but that is not an unreasonable thought at all. I often in the hospital will give baby doses of benzos or baby doses of narcotics to help patients tolerate BiPAP, to help with their anxiety, because some patients are like, I hate BiPAP, I'm not going to use it, no. And I'm like, well, you can either try it or I'll be back in 20 minutes and we're going to intubate you. I'm sorry, but that's what's happening. Like, that's where we're going with this. So please, I can give you some medicine to help calm you down. We're going to try it, okay? So if you think your patient can tolerate it from a mental status perspective and it's going to help you, absolutely. I think that's just fine.
So we had another question. Can we use push dose epi as a pressor for cardiogenic shock?
I would say yes. I don't see why you couldn't use it. I mean, so always please be cautious with push dose pressors. That's a dangerous tool, right? Because you have to mix it and you have to feel very comfortable doing it, right? We are again spoiled in the hospital and we have our little Neo sticks that are like already pre-made that we just know exactly the dosage. But even then I call out the dose and I say to somebody around me, like, this is the dose I'm going to give this, which is going to give me this much medication, like this many mics. This is what I'm giving. And somebody else will go, yes, like that's correct. So I still check it with other people, even in the hospital setting, even with pre-mixed medications, because they're so dangerous, right? So if you need a pressor, and that person's about to crump and you don't have time to hang your drip quickly, and if you feel like you have that available and it's faster, like I don't see any reason why you couldn't, but please just use it with caution.
So the other text messages I'm getting are the importance of positioning patients with exasperation for us, which in my experience is really important to position them, to sit
Oh, absolutely.
on their legs.
Yes.
To not allow them to walk until you get the fluid shift.
Yeah, I don't think, so not allowing them to walk is because you're not stressing them, right? Because these patients are already probably hypoxic, and if they exert themselves, their heart rate's going to go up, their oxygen's going to go down again, but then when you let them rest, that's going to improve again. So I don't think it's so much that you're like, you can't take a few steps to the stretcher. If they want to and they can, that's okay. But yes, I'm grateful to whoever mentioned positioning, because that's an often overlooked intervention, right? So I can't remember what resident I was with the other day, and I'm learning as a new kind of attending instructor to be quiet, which those of you that met me, that's not my default setting, right? I talk a lot and I'm kind of a hyper energetic human. So you kind of have to sit back and let the resident do things, let the intern do things. And I was sitting there, we had a patient that we sent to the CCU because they were hovering on cardiogenic shock. And they were very sick. They were diaphoretic, they were hypoxic, their blood pressure, fortunately was soft, but was okay. We did not need to start pressure, but I was talking to the son and I was looking, and the patient was almost lying flat almost, because they just brought him back emergently, threw him on the stretcher, and nursing's getting things hooked up and there's a flurry of activity. And like, he's hypoxic and they're trying to get oxygen. And in my head, I was like, sit him up. And the intern sits him up and immediately he goes from 87% to 91% with that one simple intervention, right? Because the fluid in the lungs is dependent, gives you more recruitment, gives you more area for gas exchange. So yes, like I'm grateful for that person for mentioning it, because we forget about those simple things a lot, and they can be helpful. Yes.
Yeah, a comment on positioning. Y'all get plenty of calls to nursing homes, I'm sure, and all these patients have heart failure. If your patient is chronically bedbound, they may not have like pedal edema or edema in their shins because it's gravitationally dependent. That may all be on their butts or in their low back. So just because like the patient's like, oh, I'm having exacerbation with my CHF, you look at their legs and you may be like, I don't believe you. Look at what's gravity dependent, because that's where their fluid will live. So
yeah,
that's
very caveat.
Very good.
Great point. Is a lot of times we encounter home health nursing or aides in people's homes, and we try to set them up and dangle their feet, because during the CHF exasperation, we want the fluid in their feet, not in their lungs. And oftentimes we'll get big pushback from those patient care people. Now you got to keep their feet elevated because their ankles swell. Yeah, but we don't care about their ankles swelling. Yeah.
Yeah. So just for the online folks, I just want to reiterate what Dr. Gros said, which is when you get called to nursing homes and patients are totally flat, they may not have a bunch of peripheral edema, right? Because it's independent, it might be on their back, right? Things like that. And so make sure that you're doing a really good exam. And then, yes, I absolutely agree with you. In that moment though, you know more. And sometimes it's hard to explain that, but there has to be a little bit of like, please trust me, I see this all the time, this patient, they're having difficulty breathing, they need to sit up. But yeah, that is, both of those things are very true. Any other questions? Anything else? Yeah, go ahead.
I'll say two quick things. I know we're running over time. Lasix, I would, you guys can give it, but I would not expect it to be any, like, do not give it with the expectation that you're going to see a difference from it. It's something that's going to take a little bit of time and something that's going to be a long-term effect. So if they're hypertensive, they're volume overloaded, you're thinking, I'm going to give this, how much are you giving for Lasix for one? What are you guys' dose? 40, just 40 flat? 40 milligrams.
So that is, sorry, go ahead.
And that
It's not gonna be enough.
Normally, I'm giving whatever they take orally, I'm giving that dose IV just to go ahead and
Exactly.
get them started. Because a lot of people are on, 120 milligrams of Lasix a day. So that 40 milligrams IV is really only equivalent to 80 milligrams oral. So sometimes kind of just be cautious. If you've got a long transport and you're giving somebody Lasix, say you've got a 30-minute transport, be ready to put them on a bedpan because they may go ahead and start diuresing at that point, and at least let the nurse know that you drop off like, hey, I gave Lasix 20 minutes ago, so that they're not coming back to a wet bed when they come back to. The other thing that
I can probably tell you that 90% of the Lasix that's given is probably given on the ramp at the ER.
Yes, that's fair. And that's the other thing. So I don't know how much of a benefit it's going to be for you guys all the time. I don't think it's something that's wrong to give, but I don't know how much of a benefit it is. From the flash pulmonary edema standpoint, the CPAP, these patients look like trash, but you can actually turn them around really, really quickly with the right interventions. You give them CPAP, you start them on nitro, and within 20 or 30 minutes, these patients can look completely different and demand to be discharged. You can really, really make a big impact on these patients.
The one thing that we've seen too in the pre-hospital setting is you get this great reversal with CPAP and with nitro with these hypertensive, fluid overloaded CHF patients. And then I know years ago, hopefully we're not doing this anymore, but hospital EDs used to pull them off our CPAP as soon as they got there because they were hung up on getting a room air SAD. And you would see just an immediate rebound of the they would just crash right in front of your eyes. So just be aware that the thing about that is make sure you have enough oxygen, portable oxygen to have time to transfer them to the hospital, BiPAP or CPAP, whatever you want to do. And be an advocate for your patient to continue that treatment till they're over the episode.
Yeah, so for the online folks, I don't know if you could hear Dr. Davidson, what he said, which is all very good points. So giving Lasix, it takes time, right? And Lasix is a threshold medicine. So meaning you need to cross this threshold. And one of your medics was just telling me your max dose you're allowed to give is 80. Is that correct?
What the protocol is.
So 40? So can you give it twice? Or can you do 40?
You get whatever the doctor wants.
Yeah, I think it's 40, or we can go online
and ask for more. Because 40 for these folks is probably you're not gonna reach that threshold. So you're not gonna reach that threshold with 40. It's not gonna be effective. So you either need to talk to one of us to say, yes, go ahead and slug them with whatever. And I tend to, sometimes I'll give 80 if they're relatively Lasix naive, but I'm usually giving 100, 120, just like they said. Like, again, you need to hit them hard with it, right? And sometimes people are like, oh, they're hypotensive, we don't want to give Lasix. And you're like, well, no, they have cardiorenal syndrome, right? Which is, they need that Lasix. They need it. Don't worry. They need it. It's okay. Or just get them to us and we'll give it, right? And then, yes, what Chief Ward was saying was about making sure once you put them on CPAP, which is a very important intervention, and what Dr. Davidson was saying is like sometimes they can turn around very quickly, which is absolutely true, but then sometimes you take the intervention away and they will get immediately worse again. So being a patient advocate, And hospital nursing sometimes likes to take it off so they can get their vitals done, but it's about what's most important for the patient. And as the physician, I would say, I actually don't really care what their room air stat is right now. I care about what they look like in front of me. And if they need CPAP, like at UAB, all I can say is what I do is like, I let that come off so our BiPAP can come on, and that is it. Like, that is it, that is it. And my respiratory therapy, like they're in the room, like we usually know a respiratory distress is coming. And so RT is waiting with us for you guys. But I wouldn't take that off until RT was there and we've got the CPAP and or the BiPAP and we're ready to change it out. Any more questions? These are all awesome discussion points and awesome questions.
Nope. I think we covered everything that came in online.
Awesome.
Thanks for a great lecture, everybody. We'll take just a few minute break before we move to the next question. It'll be on LVAD.
Thank you guys very, very much.
Just a couple minutes.
And sorry, Dr. Gros, we went over.
All right. So we are going to talk about ventricular assist devices, or these things that end up strapped to these people's chests once they have like real bad heart failure. So Dr. Willett gave a great lecture, I think, on heart failure. It honestly brought me back to like med school days, thinking about the renin-angiotensin aldosterone system and all that. So I'm like, if y'all follow that, I'm seriously impressed, because part of that kind of I haven't thought about in a while. So we're going to talk about ventricular assist devices. I'm going to try and keep this relatively basic and straightforward, but whatever questions you have, I'm going to try and answer. These are always one of those like low frequency, high risk type of situations, right? Most people don't have an LVAD or another type of ventricular assist device on them, and so we don't see these that frequently. So we're going to kind of discuss first what is a ventricular assist device and kind of how do they work and kind of troubleshoot them a little bit. We're going to talk mostly about LVADs because there are other forms of VADs. They're way less common, and you're not usually seeing those in the pre-hospital setting. Most of those patients are having to live in the hospital if they're on something like that. We're going to talk about some of the emergencies and complications that you may see if you do have a patient who has an LVAD, and then we're going to talk about how to best evaluate those patients because they can get a little bit more complicated. The VAD team was awesome and was able to give us some training modules. So I have them spread out in the room. If y'all just want to play with them, pass around as we talk about this, so you can see kind of what they look like. And the part that looks like almost like an engine, that's the internal part. So if you can imagine, that's what's inside your patient. So I have no financial disclosures, so I'm going to talk about some industry related products. I do not get paid by any of them. I'm a UAB resident. So ventricular assist devices. Dr. Willett gave a great lecture. What I need y'all to get from that lecture is that the heart is a pump, right? That's, if you understand nothing, I need you to understand that the heart is a pump. It pumps both to the lungs and to the systemic circulation, but at its baseline, it is a pump. And that pump can fail, right? Plenty of reasons why that pump can fail, and Dr. Willett talked about that. Big ones you'll see are coronary artery disease. We don't have a lot of that in Alabama, right? High blood pressure, cardiomyopathy, alcohol, thyroid disease, infections, genetics. We kind of talked about all these things last lecture, but these all are things that can cause that heart to fail. Mechanical circulatory support is the big overreaching umbrella that VADs fit under. So when that heart is so bad and failing that we need to put a device in place to help that heart pump, that's mechanical circulatory support. This is things like impeller devices that you may have heard of, balloon pumps. If you've heard of ECMO, that falls under here, but specifically our ventricular assist devices fall under there. Again, most of these are in hospitalized patients because they're highly complex patients with highly complex machinery. However, with advancements in medical technology, we've been able to get some of these patients back home with things like LVADs. So,
Quick, of the VADs, which ones have you seen people being discharged?
mostly LVADs.
Just
So you will potentially see like a right-sided VAD. The right-sided VADs I've all seen have been inpatient, but you could potentially have another form of a VAD. Most patients are LVADs, like 98%, 99%. You may see something weird or like a hospice patient or something like that, but if they're walking around, it's most likely an LVAD. So basic circulatory. Where's the little pointer on this right here? Here's my laser. It won't work. Oh, okay.
And you should be able to write on the.
All right. I just want you to look. This is your entire circulatory system. You have a heart that is a right side and a left side. The right side just pumps blood to the lungs. The left side pumps it to the capillaries and the rest of your body, and then it goes back. This is your entire circulatory system in a very simple diagram, right? If we have some assistance to that left-sided pump, that's that LVAD. We have assistance to that right side, that's an RVAD, or right-sided ventricular assist device, or we can put assistance on both sides. So that would be like a biventricular pump. Real basic, real simple. That's essentially what we're doing, right? So mostly about LVADs, left ventricular assist devices. This is what they're going to look like. So it's usually something that's wearable by the patient. So inside the patient's body is going to be that pump that's kind of getting passed around. That pump's job is to essentially help us get blood from that left ventricle to the aorta. So it's usually some type of tube in their body. It's connecting that pump to that aorta. There is a drive line that is both in their body, usually comes out of their belly, should be dressed, and then it connects to the controller. The controller is where a lot of the money is going to be on these LVAD patients for you. And then that controller has to be connected to some type of power source. Usually it's a portable battery that the patient's wearing. So that's what we're seeing here. So who is going to get an LVAD, right? So we kind of talked about New York heart classifications for heart failure. The worst ones are class 4. So those are these patients who they get up and take 2 steps and they look like they ran a marathon, or they have symptoms at rest of their heart failure. So this is like the worst heart failure you can have. They have to be maxed out on their medical therapy. So we've already put them on all their goal-directed medical therapy. That chronic ionotrope dependence, they're already on a dobutamine drip. They're already on a milrinone drip. They're already on all that stuff. And then by definition, if we're going to help that left side of the heart, the left side has to be what's bad. So their ejection fraction on the left side has to be less than 25%, right? So these are not going to help your HEF patients that we talked about who have normal ejection fraction. This isn't going to help them. So what are our goals for putting these in? They started off as bridge to transplants for most of these patients. That's what they were initially FDA approved for. It says, hey, this patient needs a transplant. We want to get them to that transplant. So we're going to put this device in them. They've had such great success with it that we've now started to use them as destination therapies. This patient is not a great transplant candidate, but we can give them a better life, better quality of life. So we're going to put this in, and we call that destination therapy. There's a third goal, and it's a bridge to decision. So it's you're not a transplant candidate right now, but if we do some things, we can make you a transplant candidate. We're going to throw an LVAD in you, and we think we can help get you there. So they may not be on the transplant list today, but maybe in 6 months they may be. So that's another potential patient you put an LVAD in. Interesting, I think this is the coolest part about LVADs. The first generation of LVADs that came out were pulsatile. That's the way our heart normally works, right? It squeezes, we generate a pulse, blood goes throughout our systemic circulation. And about the third generation of LVADs came out, which is like the HeartMate 2, HeartMate 3 that were passed around in the HVAD, or the Heartwear. And someone was like, do we really need a pulse? Like, do we really need a pulse? And the answer to that's really no. You don't necessarily need a pulse. There is complications associated with that. If you get down into like the nitty-gritty science. But essentially all of these devices work now by continuous flow. So they're non-pulsatile. It's either by axial flow or centrifugal flow. The slightly older ones are this centrifugal flow pump, or the axial flow pump on the bottom. The newer generations that are coming out are just using centrifugal flow. So essentially it's a magnet that's spinning, and it creates a suction effect, so you have blood that's pushed through and can go from the LV to the aorta. Simple as I can make it. your main manufacturers, especially in the state of Alabama, there are other devices besides these. So if you have someone who is traveling from Idaho going to Disney World and they're driving through Alabama, you may see another device that's not one of these. But for the main part, your Alabamians are going to either have an Abbott device, which is formerly St. Jude Medical. So if they tell you I have a St. Jude device, they're really saying they have an Abbott device. That's the HeartMate 2 and the HeartMate 3. These patients can be on LVADs for years. So they may have had their LVAD placed in 2007. And we have newer generations, but they still have the older device. We don't necessarily upgrade their device. The other company that puts these out is Medtronic. They have the hardware device. Okay. So they may not be able to tell you which one, but you can kind of put it together. They may say, oh, I have the Medtronic. So again, going over that basic LVAD structure, the money in the LVAD is in this pump, and that's what's doing all the work. The money for most clinicians is going to be in this controller, because that's where we can kind of assess that pump. And then we always got to make sure it's plugged in, right? So that's pretty much how it goes. So we're going to kind of talk about the pump itself and how we can monitor that pump's function. This is usually seen on that controller that the patient is going to be wearing. There are pretty much 4 parameters that you're going to look at on these devices. This one's displaying 3. That 4th one, pulsatility index, sometimes is seen, sometimes not, depending on the device you're wearing. So that's pump speed, pump flow, pump power, and pulsatility index. So speed, this is how fast that device is spinning, okay? This is usually a set rate, and when you look at the device, this number is not going to be changing. On some devices, they got a little smarter, and to be a little bit more precise, this may fluctuate, but it should only fluctuate by like 100, okay? This is going to be in RPMs, or rotations per minute, and this is set in the hospital. They dial it in and out using echo to figure out how exactly they can get this patient their best amount of flow, okay? Pump flow, this is physically just the amount of blood that is moving through the pump or the VAD. This is measured in liters per minute. Cardiac output is liters per minute. You can essentially use this almost as like a surrogate for cardiac output, right? Normal cardiac output is 3 to 5 liters a minute. If you have an endurance athlete who's running the Olympics, they can actually get up to like 35 liters a minute. They're crazy. So you usually start seeing problems when it drops below that 2.5 liters a minute. So think of this almost like cardiac output. This number can fluctuate, okay? Caveat, on most of these devices, this is actually a calculated number that's getting presented to you on the device. It's not actually measured by a flow meter, okay? So there can be some discretion, but if you're looking at your patient and they look like they're not perfusing well, and it's telling you that they have good flow, remember this is a calculated number, okay? Pump power. So this is how much work the pump is doing to get things going, okay? It's the amount of energy that's required at that pump speed to function that well. It's measured in watts. And generally there's a linear relationship that the more flow I have, the more power I'm going to require to have that flow, right? That kind of makes sense, right? If you have this sudden increase in power, that could potentially mean that we have something blocking that pump that I'm now having to work harder. We think about pump thrombosis, and we're going to kind of talk about complications, but this is a very common occurrence. That's why I wanted to bring it up a little early. Or there's another malfunction of the VAD. Pulsatility index, this is the one I kind of care about the least, especially for you guys. It's dimensionless. That just means that when we do the math to calculate it, all the dimensions cancel out. And it tells us essentially how much assistance the VAD is providing the patient. So it's inversely proportional to that, which means the higher that number, the less assistance it's providing, okay? These parameters are going to be patient and device specific, okay? So your best source of information is going to be the patient. Hopefully they can give you that information. If not, these patients are supposed to have a 24/7 caregiver who's trained in how to assist the patient with these devices. They should also be able to give you this information. A normal pump speed you can see can vary from as little as 2,800 up to 15,000. So these numbers, again, vary widely depending on the device that the patient has. Flow is usually 4 to 6, right? That makes sense, right? That's our normal cardiac output. It's about 3 to 5. So it's going to be around there. Pulsatility index and pump power, again, vary depending on machine, but the one that'll vary the most is your pump speed. And they're also patient specific. So they give the patient, like, these are where your numbers should be. So kind of how every patient tells you, like, oh, my blood pressure is always low, or my heart rate's always 50. Alarms. So that controller, if the device is yelling at you, look at the controller. The controller is going to tell you why it is alarming. It'll maybe say connect battery. So we're going to try and connect battery. It'll say low flow. It'll say something like that. So it'll kind of give you an idea as to where specifically do we want you to troubleshoot this device. Okay. There's different types of alarms. Most of the devices are smart, and they may have like a yellow alarm that is more of a, hey, your battery's going to die in the next hour. And then there's like red flashing alarms that are like, hey, you got 5 minutes. So they kind of prioritize the alarms a little bit. Where do these patients live? Ideally, if you have a VAD patient in your area, the coordinator should be getting in touch with you and providing training and doing all this good stuff to let you know that you have this patient here. So that way you and your team can be prepared for that. I say should because y'all know that y'all deal with a lot of things that should not be. The other thing is that people travel, people move, right? You can't expect these patients to live in a silo or in a certain rescue district, right? So they may be an hour away from home visiting family, and you may encounter this patient even though you don't have a VAD patient in your district. So we just always want you to be prepared for that. In Alabama, these are the patients who have gotten their VADs in. I think I pulled this from a presentation that was given to us, and that was devised in like 2019. So these may change, but you can see they live throughout the state. Some of them even live in Mississippi because they don't really have a VAD center that's close to them. The VAD center is in Birmingham. So if you're in kind of the further outreaches, Birmingham still may be your closest VAD center. Any questions about that before we move on to VAD complications that we got? Yeah, cool. All right, so complications, these are things we worry about, right? These patients are walking around normal. They go to Walmart like the rest of us. They go out to eat like the rest of us. We don't worry about them then. We worry about them when things go wrong. I kind of subdivide this into things that are VAD related and VAD specific, which kind of, I don't necessarily know if those definitions make sense, but they make sense in my brain. So things that are related to VADs are things that can happen to anyone else, but because they have a VAD, they're going to be at an increased risk for this. So stroke. These patients are at roughly a 7% increased risk of stroke. So this isn't specific to their VAD, right? You're not going to be troubleshooting their VAD, but this is a medical emergency that you need to be more keen to look at if you ever get called on a patient as an assist device. This is both for ischemic and hemorrhagic strokes. We'll talk about this a little bit more. Bleeding. These patients are all on blood thinners, so they will bleed. They can also get renal failure, hypertension. Their heart failure can actually just not respond to this. We'll talk about the ones in bold a little bit more. And then I consider these other ones that are VAD specific. So these are things that are wrong with the device or the machine that's helping this patient. Equipment failure. The device is not plugged in. It has to be plugged in to work, right? If you have a suction event, we'll talk a little bit more about what that is, but essentially you have impeded flow through the device because it becomes obstructed by the ventricular walls. Infections are incredibly common. We'll talk about that some more, and then pump thrombosis. So stroke. These patients, again, are at about a 7% increased risk of stroke by just putting the VAD in. It is both hemorrhagic and ischemic stroke. So we are putting a foreign body into the left side of their heart, okay? When things come out of the left side of the heart, they go to systemic circulation, and that includes the brain. If I have a foreign body somewhere, I'm increasing the risk that I can form a clot on that foreign body, and that clot can propagate and get thrown to the brain. That's an ischemic stroke, right? That's something we would worry about. On the other hand, they're also at risk of bleeding into their head. We don't want those clots to happen. So what do? We put these patients on blood thinners. They are on chronic, lifelong anticoagulation. They're usually on warfarin or Coumadin. And we have a goal INR of about 2 to 3 for these people. And then they also, just if you start to get really into the weeds about the clotting cascade and what it takes to form a blood clot, they developed something called von Willebrand's deficiency. Essentially, you need von Willebrand factor to clot, and because of the way of the mechanics of the VAD, it can kind of shred those particles, and so we don't have those. They're not functional. So these patients have a harder time clotting, so they're at an increased risk of bleeding into their head. A lot of these patients are hypertensive, right? So that the hypertension increases their risk of stroke. So if you come on a VAD patient and they are having signs and symptoms of stroke, do your normal assessment, but they also still need to get to a stroke center, okay? So do your typical pre-hospital stroke assessment. Don't forget your glucose, right? And transport to a VAD center if able. That VAD center in the state of Alabama is UAB. That's where we'd ideally like all of these VAD patients to go. We'll talk a little bit about some other scenarios where they may be okay to go to other places. So bleeding. We talked about that they may have hemorrhagic stroke. They can bleed at other sites too. So we kind of talked about why they bleed a lot. But nosebleeds, incredibly common, incredibly hard to stop because these are anticoagulated patients. Your approach to bleeding is the same as in a non-VAD patient. Direct pressure and go from there. If GI bleeding is also incredibly common. So one of the things we talked about, how these patients don't have pulses, it actually increases their risk of developing arterial venous fistulas, where their arterial system connects to their venous system, and they are at an increased risk of having more brisk GI bleeds because of that. There's actually some really interesting evolutionary data out there as to how pulses relate to higher functions. Really cool stuff. If you ever have the time to just nerd out on it, it would make like a great Nat Geo documentary. So what I want you guys to remember about these VAD patients, though, when they're bleeding, is that they are incredibly preload dependent. So if you have a massive GI bleed and they lose all their preload, their VAD is not going to function the way it needs to function, and they need to be volume repleted. Okay. Typically, that's going to be in little small 250 milliliter or 250 cc aliquots. Ideally, we're replacing blood with blood. So as we get more blood in the pre-hospital setting, I would love to see blood being replaced with blood. But they are also incredibly afterload sensitive. So that VAD is having to work against the high pressure system of the peripheral circulation. And if we give them too much product and we actually increase that afterload, we've now made that VAD have a hard time working, and they may actually have a worse outcome. So these patients' volume statuses are so, that's why I had the little balance scale up. Like, they need to stay in that perfect balance. Anything that throws them off of that could make this patient worse. We always like to talk about TXA in the pre-hospital setting for bleeding, right? This is a patient that I would want you calling potentially online med control before you're giving this patient TXA, because by giving TXA, we actually may cause a pump thrombosis. So this is not just a online medical director, one ED doc who's making this decision. If we're in the hospital and this is going on, this is a multidisciplinary decision between our advanced heart failure team, the cardiac surgeons, whoever's the primary lead on that patient. So I would not expect you guys to make that call on your own, because we don't even make that call on our own as physicians. This is definitely multi-specialty, multidisciplinary care. So always consider, before you're going to reverse these people, talk to online med control. Okay. Equipment failure. This one is pretty common. The batteries died. Their driveline got disconnected from their controller. If the driveline's not connected to the controller, the pump doesn't have power going to it. It's not going to work. So again, the alarm systems for on most of these are prioritized. You can have a low priority alarm, a medium priority alarm, and then high priority alarms. We can kind of talk more about alarms in a little bit, but there is a really good resource that if you would ever look up, this Mechanical Circulatory Support Emergency Guide. This is put out by a group of clinicians who deal with mechanical circulatory support, and they have this quick guide on there that can kind of help you, like, how do I put the battery back in, or like how do I connect the drive line back in to the controller. Okay, because a lot of these things, it may seem as simple as plugging in like something into a power socket. It's a little bit more complicated because a lot of these devices have safeties on them so that they do not become dislodged. So sometimes you have to mess with a safety to get it to fit in correctly. Okay. Suction events. So right, the way this VAD works is we're taking blood from the left ventricle, diverting it around to the aorta because the pump works better than the left ventricle. But sometimes this suction is so strong that it actually causes the ventricular walls to collapse and obstruct the pump. Okay. So this suction event, the way you fix this is you give the patient more volume. Okay. So we need to expand that ventricle again. This is not something I would necessarily expect you guys to diagnose in the pre-hospital setting, but it's something I just want you to be aware of. So if you have a sudden increase in the work that your pump is having to do, so you get a high power, low flow alarm, this is something potentially that can be going on. So if they tell you, yeah, I've been feeling real bad, and so I like tripled my dose of diuretics, and I also have been in the desert for 4 days, and like they're like very, very, very volume down, this could be potentially what's going on, right? Again, these patients are very, very volume sensitive. Incredibly common is infection rates. So these drive lines do get infected. It's a foreign body. And then we're sending these patients home and expecting them to keep a good job of keeping it clean. And even if they do the best job, sometimes they still get infected. Up to 40% of these will get infected in the first year. Okay. And then we also, not just the drive line, remember that drive line's connected to the pump, and that pump's right in the heart. So you're essentially almost like a setup for having septic emboli in the left ventricle, or like an endocarditis picture. These patients are at high risk of sepsis. Super common. And again, most common in the first year. So a lot of these patients, they'll call their coordinator and they'll be like, hey, I have a fever and this looks a little red. And that coordinator will be like, get to the ED now. And it's essentially, it's early antibiotics. We want to try and save this. We don't want this pump getting infected. Pump thrombosis. So this is kind of what we talked about a little bit. So we have them on blood thinners, but sometimes they miss a dose of their Coumadin, or sometimes they have some other issue, or sometimes this stuff just happens where we develop a blood clot in the pump and the pump stops working. It may either work not as well or it stops working completely. Again, things that are going to clue you into this is that history of, I forgot to take my Coumadin, or they actually, so the way Coumadin is metabolized by the body, it uses CYP enzymes. So if they get put on another medicine, or they start taking some holistic remedy, that can actually interfere with how their Coumadin is metabolized and can increase or decrease their Coumadin levels. So it could be something as simple as I started taking a new product from GNC. Okay. Again, it's going to increase the amount of work it's doing, so you're going to get a high power alarm. It's going to decrease the amount of flow that's going through the pump, so you're going to get a low flow alarm. Potentially your pump may stop. Okay, and we'll talk about how you know if the pump has stopped. So, any questions about the VAD at this point? All right, we're going to talk about evaluating this patient and how are we going to approach the patient who has an LVAD. I don't know if you've seen Grey's Anatomy. It's something I know my wife was obsessed with back in the day. There's an episode in it where one of the residents cuts an LVAD wire on a patient, I think to like try and help him. Don't cut the LVAD wire is probably the best thing you can learn from this. I say this jokingly, but also LVAD patients are normal patients and they may be involved in a trauma. Okay, and what are we doing in trauma? We are exposing these patients. So if you have You go up to this patient, and you see they're wearing one of these devices, please be very careful with your trauma shears. Do not cut through the drive line or another power source or anything like that, because you've now just messed up that LVAD. Okay, so please don't cut them. Your ABCs, still the most important priority when evaluating an LVAD patient, just like any other patient. So we'll walk through some of these vital signs. You're going to still do your general assessment, make sure you're scene safe, all that fun stuff that we all do. Pulse, remember, a lot of these newer devices are continuous flow devices. Your patient may not have a pulse, okay? And that is a weird thought, but you will go to feel for a pulse and you won't feel one. Some of them may have a pulse, okay? Some of them have enough intrinsic cardiac activity where they're able to generate both the diastolic and systolic flow, so to speak, and they're not really on continuous flow. So the way you're going to kind of do the pulse is you're going to put your stethoscope over and you're going to make sure you're hearing this precordial hum, okay? That tells you that that's what you're hearing is that spinning of the pump. That tells you that my pump is working, okay? Really the way you're going to say, hey, this is what my patient's pulse is you're going to get an EKG. You're going to get a rhythm strip, okay? That will help you look at both their rate. That's really the only way you can assess rate, and it'll also help you look at their rhythm. These patients can be in whatever rhythm they so choose. The device does not, the LVAD does not pick a rhythm for them. These patients usually, or they should, have gone through maximal medical therapy. That involves ICD placement. I don't think that there's an LVAD patient out there who exists without an ICD, but there's always that weird exception for something, right? So they will probably have an ICD in place, and you may see evidence of that ICD on your rhythm strip. So they may potentially be PACE as well. Blood pressure. How do you get a blood pressure on someone without a pulse, right? Ideally, the way we're doing this in the hospital is you're using a Doppler measurement. So you're putting it over the brachial artery or a distal radial artery. You're inflating your cuff, and then you're deflating your cuff. And the number you hear is where you have that continuous flow, and that's actually your map, okay? Traditional methods, you can get a traditional blood pressure measurement if that patient still has enough intrinsic cardiac activity to develop a systolic and diastolic pulse flow. So I'm not saying you can't take a normal blood pressure, but most of these patients you probably won't be able to take a normal blood pressure. You're gonna have to use something like Doppler. Pulse ox relies on a pulse. So that's another thing that we're going to have difficulty getting, right? If we don't have pulsatile flow to our fingertips, our nose, our ears, wherever we're trying to get it, you may not get a good reading. So if you don't have a pulse and you throw a pulse ox on a patient and the pulse ox is reading 70%, but they're sitting up talking to you, I wouldn't necessarily trust that 70% number, right? Treat the patient, not the monitor, not the machine, not whatever we want to talk about. Temperature is the same. Respirations are the same. The LVAD does not affect these vital signs, okay? And then after you're done looking at your patient, right, because that's really one thing I want to treat, I want you to look at the pump. Look at the LVAD itself. Check if the thing is yelling at you, that it's trying to tell you something, okay? Go to the controller and see why it's yelling at you. It may tell you low flow. It may tell you like connect to battery source or battery power low or something like that. So look at the controller and see what it's trying to get you to do. Use the patient if you can. They'll be able to tell you their normal numbers. Or their 24/7 caregiver should be able to tell you their normal numbers. They may say, hey, they normally have a flow rate of 4, and you're looking and that flow rate says 9, okay? Or they may have a normal flow rate of 6, and you look and that flow rate says 1. That's not right, right? So use them as a resource, okay? And then listen for that precordial hum. If they have an LVAD and you put your stethoscope and over their precordium and you listen and you don't hear a hum, it's not working, okay? So that's how we're going to assess this LVAD. Other considerations on LVAD patients. Have y'all heard of like Occam's razor versus Hickham's dictum? Okay. Oh, yes. Yeah. So this is, I brought this up to Ferg the other day. So this is something that they teach in medical school. Occam's razor is like, hey, I have a patient who has wet lungs, peripheral edema, trouble breathing, and they've had 5 heart attacks. Occam was a physician in the Middle Ages who said, duh, this is heart failure. You don't give a patient 8 diagnoses when they all combine and become 1 diagnosis, right? And then there was a snarky physician, Hickam, who worked in like the middle of the 1900s, who said, well, a patient can have as many diseases as they damn well please. Okay, so he said that you can have 5 heart attacks, trouble breathing, volume overload, all this stuff, and oh, you actually have hypothyroidism and CHF and postpartum cardiomyopathy and like all these other diseases. Okay, I bring this up because you may get a call or you may be seeing an LVAD patient or a VAD patient, and they're there because they sprained their ankle, right? That has absolutely nothing to do with their VAD. They may say, I have trouble breathing, but I've also had a fever and I've been spitting up like purulent stuff. They have pneumonia, right? These patients can still get things that are not VAD related. And I don't want you guys to get so clued in on, oh God, there's a VAD here, that we forget about all the other normal things that can happen to these people, okay? So continue your standard protocols for whatever else is going on. If it's a trauma patient, I want you to treat them like a trauma patient. Still use your C-spine precautions, still do all that stuff, just please don't cut their LVAD, okay? Good question that always gets asked, right? My patient doesn't have a pulse, they're unresponsive. How do I know if they're dead, right? How can I tell if this patient is arrested or not, okay? What we're going to do is we're going to look for signs of perfusion. If that patient is sitting there talking to you, they're not dead. The patient, right, simple things. So I'm a simple guy. That's why I went into emergency medicine. If they are unresponsive on the ground and they don't have a pulse, they may be dead. They may not be dead. They may be unresponsive for another reason, right? They may be so hypoglycemic that they're not responding to you. You still need to check a glucose. They may be hypoxic, and that's why. Prior to 2017, the AHA did not give us many guidelines on what to do with these patients. So it was pretty much the device companies were telling us what to do. And prior to 2017, all the device companies said, specifically when it came to compressions, is don't do compressions, you can dislodge the LVAD. AHA came out in 2017 and gave us this algorithm. And this is really what I want us to focus on a lot today, is this algorithm. So if you have an unresponsive LVAD patient, look for signs of perfusion. Is their skin color normal? Are they blue? Are they cold? Are they warm, right? Are they breathing? That's another great question. Do they have normal capillary refill? Yes, they're doing all those things. They're perfusing well. You listen. Their VAD isn't alarming at you. You hear a good precordial hum. Like, they probably have something else going on. So let's think about those other things. LVAD patients potentially can have fun too. This may be just a straight up like opiate overdose, right? So it could be other things. You always have to keep that in the back of your mind. Remember, stroke. If this person has a pontine stroke and they have like a locked in syndrome, they won't respond to you. They won't do anything. They'll just be moving their eyes. VAD's working perfect, but they had a pontine stroke. Remember, 7% increased risk of stroke. So the AHA just says follow your guidelines for that stuff. What you got?
Set the LVAD, everything here, we're working fine, they're still unresponsive, and you run a strip and they are like somehow the strip says like VTAC or VFib. Does it address defibrillation anywhere up in there?
We'll talk about ACLS specifically, the algorithm, but great question. Great. I'm already glad you're thinking that. Dr.
Also,
Willett.
there's another intervention that we can use. We also hammer these guys with cardiac arrest, like what vital sign measurement.
Oh, we're gonna get to that.
Oh,
I have it nice and circled in the middle.
oh, perfect. Sorry, I can't see.
So that was the LVAD is working fine part of this, right? So they're adequately perfusing. What if your patient does not have good signs of perfusion? They're cold, they're blue, they are not breathing. Assess that LVAD, right? Listen for your precordial hum. Look for alarms that are going off on that LVAD. If that LVAD is functioning, it may be functioning, but it may not be functioning well enough, right? So that's this part of the algorithm. This is where we want to look at a blood pressure. If that blood pressure is greater than 50, that map, they should have adequate perfusion. Okay. Normally you could use a Doppler, okay, which I know you guys don't have. You can try and get a manual blood pressure and try and how am I going to say this? If you have any intrinsic cardiac activity, you can try that. If you absolutely have to, you can use an automated blood pressure, because how do automated blood pressures check blood pressures?
I guess.
Very close. It does kind of guess, but how does it do it? How does it guess? Yeah, so what it does is your non-invasive blood pressure monitoring is actually measuring a map, okay? And it's guessing a systolic and it's guessing a diastolic. So the guessing is kind of correct, right? But if you tell me, it's kind of one of my pet peeves, if like someone's on non-invasive blood pressure monitoring, just a regular blood pressure cuff, and someone tells me, oh, their systolics like 140 or their systolics 90. That's not what that machine's measuring. That machine's measuring their map. I trust that map more often. Okay. So if you have to, which I know with most of you guys are going to be resource limited, just use your non-invasive blood pressure cuff and use whatever that map that gets poured out at you. Okay. The other thing you can do if this patient truly is unresponsive, they're not breathing, anything like that, put them on capnography. Put them on capnography, put them on capnography, put them on capnography. Okay. If that capnography is greater than 20% or greater than 20, not percent, just greater than 20 millimeters of mercury, don't do chest compressions. They're adequately perfusing. Okay. There's something else going on in this scenario. That means for some reason, they look like they're not perfusing well, but their VAD is functioning. So there's something else going on. Okay. If their end-tidal CO2 is less than 20 or their MAP is less than 50, since 2017, the AHA says, yes, do compressions. Please do compressions. Okay. I don't know if y'all were able to look at the devices in there, but that little cylinder that's popped off is literally sitting in the LV. Okay. There is a chance that you can dislodge that while doing chest compressions. The argument, though, is that this patient is not perfusing. They are dead. You can't get more dead than dead. Right.
Is there any recommendation for or against compression automated devices?
I personally would not use a Lucas device because of how great those compressions are technically, right? So really, if you look at the AHA guidelines, that isn't on this diagram, but if you actually look at the actual guidelines, they say gentle compressions. Okay. They don't define what gentle they don't define what gentle compressions are. I would do compressions while they're on end tidal and try and get that end tidal back up. Okay. Which said?
Nursing home.
Nursing home compressions. So they say gentle compressions. If you like, I mean, y'all all have seen a Lucas run. They work excellent. It's why when you're running a code, you palpate a femoral pulse, you're like, oh wow, that is working, right? I personally would not recommend using a Lucas device. I would do manual compressions on these patients. Just because I think you also get that feel of like making sure that you're not doing more harm than good. Okay, let's say we're back there though. So we kind of worked down this algorithm here. We were assessing our LVAD, and that LVAD, oh wait, I didn't hear a hum. Oh wait, it was alarming, right? We're gonna try and fix those issues, okay? Before we start banging on chest. Is the drive line connected? Physically look at the drive line. The alarm, for some reason, it's a machine. Machines malfunction because they're made by humans and humans malfunction, right? Make sure that drive line is actually connected to the patient. Make sure the power source is plugged in. Make sure the battery looks okay. The machine should tell you what needs to happen, okay? So if it's alarming, try and correct that alarm. What you got? No dumb questions, just dumb people.
Line's connected.
Mm-hmm.
Like it's going to still be inserted into them.
Yeah.
Have you ever seen it not inserted into them?
Missing the drive line.
So
Like it's not in.
if I can imagine, I've never seen that, but I can imagine in potentially like a traumatic situation where that gets pulled, something like that. That's not working anymore. obviously.
You're not gonna.
You're not going to be able to control that situation.
I'm
Yeah.
just saying, it's.
Yes. Yeah.
There is no protocol for going fishing for that thing.
No, I would not. At that point, what you would probably do, well, honestly, they're probably going to bleed. You're going to be holding direct pressure and giving them a very, very large diesel bolus while you're trying to get them to the hospital and pray that they have intrinsic cardiac activity.
Okay.
Okay. There's just some things that we cannot fix, and that may be kind of one of those, like, there's some traumatic injuries that are not compatible with life. That just may be one of that for that patient.
Said it's in the belly and.
Yep. So there is a potential that that thing can get pulled. So.
Usually it would be.
Yeah. Now there are safety mechanisms to keep it in there. There are safety mechanisms to keep it in there, but again, these are machines. Things break, things malfunction, right? Let's go back to this slide. So we kind of worked through this algorithm, right? Does anyone have any questions about this algorithm?
Is that on the AHA right now?
This is on the AHA. So I know this is our guidance from the AHA. All right. Someone asked a question about, I get a rhythm strip and it's telling me VFib, VTAC. What do I do? These patients should have ICDs, and those ICDs should be functional. Those are big shoulds, right? They don't always work. I had a patient the other day in the ED who was in VTAC who had an ICD in, and ICD wasn't doing anything. So we had to be the ICD. Okay. ACLS drugs, give them as appropriate, and by that I mean follow your ACLS guidelines. If your LVAD patient is an SVT, you can push adenosine. If your LVAD patient is in persistent VTAC and they are hemodynamically unstable, shock, give amiodarone if it's persistent. You're still following those same algorithms. Treat this LVAD patient as if they did not have an LVAD. Okay. Again, the ICD, most ICDs are also pacemakers. Okay, especially all the ones that are placed now. So remember that you may be looking at a paced rhythm when you're doing your strip interpretation. Okay. Again, theoretically, this should defibrillate the patient for you. It doesn't always happen. Specifically, when we're putting our pads on, we want to try and avoid the device. We don't want to shock the device. We want to shock the heart. So just don't put it, if you can palpate the device, which sometimes you can on these patients, try and put it away from the device and just make sure you're going through the heart with the pads. Okay. You can use that AP positioning, or they actually have also described using bilateral lateral chest positioning here. If you're going to do this, I'm going to warn you, you're going to need a whole lot more joules than just 200, right? You're going to need more high energy to make it across more tissue. Okay. Transport considerations for LVAD patients. LVAD patients have a friend. They're required to have a friend. It's part of having an LVAD. That friend with them is trained on how to troubleshoot that LVAD and to help them if they ever need to change a battery and they can't, or something like that. Use them as a friend and a resource. They are there to help you. Okay. When the patient needs to be transported, that friend comes with them. That friend comes with them, and their backup device, battery pack, controller comes with them. Okay. If you transport a patient and we don't have that stuff, we're kind of, and then their power goes out, something like that, we could potentially end up a creek without a paddle. Okay. So make sure they have their friend and their backup power system. And then try and transport them to the VAD center. The VAD center is UAB. Was talking to Dr. Ferguson before this. If you are not anywhere near Birmingham, you are 3 hours away in the sticks of Alabama, and you have a patient who is obviously cold and dead, who happened to have been wearing a VAD, you can call online med control. We do not necessarily expect those patients to get transferred to the VAD center. If that patient is alive at all, we want them at the VAD center. But if it is like a very obvious death, we do not need to transport them, take up resources to move them for 3 hours to Birmingham for just to have one of us declare them. Okay. There are other doctors at other hospitals who should be comfortable declaring death. Okay. Any signs of life, though, we want them at UAB. Okay. So summary, we're going to kind of talk about what we talked about. Ventricular assist devices, right? They're mechanical devices that help a failing heart. That's why they're there. These patients are at an increased risk of stroke, bleeds, infections, and equipment malfunctions that are inherent to it. When evaluating an LVAD patient, your ABCs come first. And remember, your patient may not have a pulse. So you have to kind of get around that to assess them. Assess for perfusion. Look at things like their mental status. Look at things like their skin. Look at things like their respirations, if they're functioning. ACLS drugs as appropriate. These patients fit in the typical ACLS algorithm, depending on dysrhythmias, as like you would normally treat a non-LVAD patient. Chest compressions are a thing since 2017. If you have an end tidal less than 50 or a MAP less than 50, okay? If you don't have those things, kind of treat as appropriate, okay? And then any signs of life, patient is alive, we want them at the VAD center. The patients are instructed and their caregivers are instructed to notify their VAD coordinator anytime they're going to the hospital. So they will call their VAD coordinator. They may ask you to call their VAD coordinator. Usually they do it themselves, to let them know, hey, I have a fever. I'm coming in the hospital. I'm worried about a driveline infection. Or, hey, I have this persistent, I have this intermittent high power alarm. I'm coming to the hospital. So that way we know we can get our advanced heart failure team ready. Honestly, most of these patients have a bed assigned to them before you guys even get to us. So the earlier notification that they're coming, it's kind of like a trauma. Like, we want to have the team and we want to have our resources ready to take care of these patients. Okay. So a couple other notes that Dr. Ferguson asked me to make. We talked about mechanical circulatory devices. These are two that I want to talk about because sometimes you may hear about them when you're following up on patients, especially post-STEMI or post-MI or anything like that. Impella's, it's a company, so that's what it has a little R thingy. I did not come up with the name. In balloon pumps. So an Impella is like a temporary LVAD, okay? It's something that's inserted through a major artery, usually a FEM, sometimes a brachial, and it sits in the LV and it sucks blood up through the LV and diverts it out into the aorta. So it essentially bypasses this LV and this left ventricular outflow tract. So if you have a patient who has had a massive MI, there's this concept called myocardial stunning, where for a very short period of time, maybe a couple days, their heart just does not beat very well at all. Okay. They can regain that function, but for a couple days, they're just not, that heart's not doing much. That LV is not doing much. And we can throw one of these devices in to help buy them time through that myocardial stunning period. Some of these patients, if they develop chronic heart failure, we then are going to be doing all those chronic medical therapies, inotropes, blah, 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 all that fun stuff. But you may hear about, oh, they had an Impella device placed during their PCI. Another common thing you're going to hear that is potentially placed during PCI, actually, I think UAB is doing a study, by the way, on this. Impella, yeah, the Impella assisted PCIs. So they're randomizing patients to get these during their PCI, kind of regardless of if the cardiologist thinks it's indicated or not.
For long, because after the Impella goes in, you have to wait 30 minutes before you can even shoot the coronaries to do the PCI.
And part of the reason why, right? So when they're doing that PCI, they're coming in right where this aorta pops off. So the heart's smart, and it says, if I'm going to pump blood, I'm going to feed myself first. So your coronary sinuses, or where the coronaries take off, are right at there. So they get the freshest, most oxygenated blood. So whenever they pass that there, you start having real estate issues potentially at the coronary sinuses when they're trying to go in and stent and balloon those coronaries. Okay. And then you will also sometimes hear, hey, your patient ended up on a balloon pump. Okay. I think these are like the coolest things on the planet, personally. So it's a balloon that we put in the aorta typically again through my femoral artery site. And this balloon goes in and sits above the renals. And when we're in systole, the balloon's down. Makes sense, right? If the balloon's up when we're trying to push blood, it's not going nowhere. So we need the balloon to be down during systole. It's smart, and when we're in diastole, the balloon inflates. And what that does is it helps push blood back into those coronaries. So we're prioritizing perfusion to the heart, because that's what just does not have great perfusion. What's actually, I think, the coolest part about this is when this balloon goes back down, it actually creates a suction event, and it helps forward flow of blood. So it actually unloads the LV, so it's not working nearly as hard. Okay. These are one of those things that it's like, wow, that makes so much sense. And it's kind of a simple concept, but I wish I had come up with that. So the way you'll see this is these tracing. So this is a normal unassisted blood flow. So you have about 120 millimeters of mercury, and then you have your dichrotic notch. So this would be like a normal A-line tracing, right? And so I have my normal systole, and then I'm going into diastole. That's why I have that dichrotic notch, right? My aortic valve closes. I have that little bump in pressure. But instead of having that dichrotic notch, I have diastolic augmentation. I have that balloon that comes up, and I actually have an increase in my pressure. So these get placed in a lot of patients who look like they're in shock post PCI. And what we'll do is we'll have them beat to beat. Every beat they're getting assistance, and the way we wean them is we go to something like this where it's a 1 to 2, and then we space them and we do a 1 to 3, a 1 to 4, and then eventually we're like, we don't need to use this anymore, and we take it out. Okay, so this is another form of mechanical circulatory support that you may hear about in your patients. Okay, just want to take the opportunity to talk about those two things, and that is it. I'm sure there are plenty of questions.
About the VT, you were asking about shocking somebody. These patients do have ICDs, but if they have a slow VT, their VT zone is probably set on the ICD to shock at a rate of 120 or 140. So if they have VT at a rate of 110 and there's no shock after like 15 or 20 seconds, then y'all would need to do it.
Yeah.
Because it's not going to go off.
Yeah, those devices are programmed. Right. What you got?
As far as, let's say they come out with chest pain, we get there and they're in LVAD. Putting a 12 lead on, is the pump going to mess with us reading our leads down here?
Sure.
Okay.
No.
So their like organic underlying rhythm, as long as it's not paced, should be unaffected by the LVAD. So you should still be able to obtain and interpret your EKG.
Potentially it's a pace rhythm though, right?
But
They have ICDs. Yeah.
Right?
All those devices you just went over, they're not leaving the hospital with those. Those are.
These are not leaving the hospital.
Okay, then.
Yeah.
We're gonna see
You're never going to see these, but
mostly those are gonna be like transporting.
yes. These are not going to leave the hospital.
Interfacility stuff, like if they get a catheter outside the hospital, get transferred for cabbage or something of that sort, that's generally what these patients will have.
Yeah.
Yeah, that's it.
That's
Not in the house.
Not me.
That's correct. Not in the house.
Yeah.
That 1-to-1 from the time it turns on is probably the most impressive thing. Watch the return of color. I mean, it's instant change.
One of the coolest ones I've seen is, so there's a device that Impella puts out. It's called an Impella RP. Okay. It's a right-sided Impella. And so you can essentially bypass the right ventricle. So this was a patient I helped take care of who had an inferior MI. So the right side of their heart was just down. They're in the outside hospital, and every time they would go to stent that, they would occlude flow, and the patient would bring you down and arrest. They tried twice, and they said, "We're not doing this no more." Transported them to UAB. They went to our cath lab. We threw in a right-sided Impella. We said, "Screw the right side of the heart. We'll just bypass it." Put the Impella RP up, stented the RCA, pulled out the right-sided Impella, came to the CCU. On dobutamine, sitting up talking to me, like, you don't need dobutamine, and we discharged them the next day. So these devices are like crazy. I love them. I think they're the coolest things.
Hey, great lecture. Thanks, Doc. Really appreciate it.
Any questions from?
Can I ask one quick question? You said that algorithm was on the one with the circle that gives them, they're like, how to evaluate. That is on the American Heart Association.
It should be. It should be. I pulled this directly from the NHA guidelines.
It's not in ACLS, so don't.
It's not in ACLS.
It's in the other protocols, like under
maternity cardiac arrest, and other cardiac arrest circumstances.
And Dr. Gray, I do, some of the old, I don't remember if you mentioned it, some of the very old LVADs have pulsatile flow.
Yes.
Most of those patients are probably dead by now because they realize that pulsatile flow in an LVAD is actually not good. He talked about the benefits of pulsatile flow in a normal human and a normal heart. It's good. So they thought it would do well in an LVAD. And in fact, does not. So all of these that we see now should be continuous flow. Close the door on him.
Hey, thanks for 2 great lectures today and great discussion, everybody. Thanks to Chief Harvey and the Fire Department for hosting us, as always. Thanks to Alabama Fire College for sponsoring Alabama EMS Challenge. We do want to say congratulations to friend of the EMS Challenge, Matt Crow, who was awarded the American Legion Firefighter of the Year this week. So great job, Matt. And what you got, Dr.
That was it. Thanks, Springville. Really appreciate what y'all guys do out here. Thanks for supporting the EMS Challenge. A couple of updates, things that are coming. I guess they can hear me now.
I can. You're good.
So I know that times are tough right now, staffing issues and healthcare wise, both hospital and pre-hospital. There are changes coming to the pre-hospital that look good for us in the future. There's a data exchange I mentioned earlier. There's also more of a recognition that EMS needs to be brought into the family of true healthcare, right? Even though you already are. So don't get excited. That family is dysfunctional. Okay. There's some issues there. But that being said, that means there's more funding coming to that, right? So community paramedicine, there's telemedicine aspects that's going to bring money into this as well. There's also the ET3 program that's where you can potentially treat on scene, get bill and get paid for that and not even transport the patient. So in the next few years, as long as we keep our head on straight, things are looking better for us. We got a couple of rough years ahead of us still though. So that's all I got to say. So that's it.
Great. Awesome. Thanks, everybody. We'll see y'all next time.